on tension pneumothorax. In the first session we looked at the difficulties in diagnosis. Okay, we know the guy's deteriorating, it could be a tension. If they're deteriorating, the tension is getting worse. So even if you needle the chest and let air out, don't forget that air is still going in. And what you need to do is to let air out faster than it's going in. You don't know how big the tear in the lung is, and consequently you might need something a lot bigger than a wide bore cannula. But first of all, let's try and confirm the diagnosis. You need to decide which side is the pneumothorax, if not both sides. So, we're talking about now something called Poiseuille's law. Poiseuille was a mathematician and physicist born when Napoleon came to power. His law explains flow rates through tubes, and it's got a great deal of importance to cardiovascular physiology. Now, intravenous cannula makers use Poiseuille's law because to get maximum flow rates, not only do cannulae need to be wide, they also need to be short. For a chap like this, that's not a problem. But the world's getting fatter. Women have breasts, and those who do go to the gym to keep fit have a good chunk of pectoral muscle. The wide bore intravenous cannula is simply not long enough for possibly over a third of patients. If you take this piece of meat, then obviously you don't have a major problem. There's a reasonable amount on the other side. But people do actually have flesh on them as well, which rather changes your problem. A wide bore intravenous cannula might not penetrate the thoracic cavity, and even if it does, there won't necessarily be enough on the other side for it to be safe, and the slightest movement of the pectoral muscle will actually drag the cannula back out. So a wide bore cannula, intravenous cannula, may suggest that there is no pneumothorax in a third of the patients who are dying in front of you. And this thing may not let the air out as quickly as it's accumulating, even if it is in the pleural space. So you've got two options. The first is to use a specifically designed needle thoracostomy device. And although I had some input into the development of it, I do not have any commercial interest in this device. I would recommend the ThoraQuick. I'll make sure that there is a link to explain how this thing is used, but you will see that there is enough room. This has a one-way valve in it, and these tapes will stick it down onto the person's chest. So, admittedly they're about 40 times the price of a cannula, but the alternative option, if you've got a failed needle thoracostomy, or even if you've got a successful one and you've discovered that there is a tension pneumothorax, is to then go on and do a chest drain. And the Portex chest drain kit costs the same price as a ThoraQuick. In the pre-hospital environment where things are not particularly sterile, I think I would go for the simplest technique because it is keep it simple. It tends to be taught that needle thoracentesis needs to be done at the second interspace in the mid-clavicular line, and chest drains are done in the anterior or mid-axillary line above the fifth rib in order to avoid the diaphragm. Instructors may talk of keeping anterior to avoid the long thoracic nerve of Bell, and they almost certainly will go on talking about going above the rib below rather than below the rib above, because you need to avoid the neurovascular bundle. This is the neurovascular bundle. It's not too big and it's protected fairly well by the rib, so don't worry too much about it. All of this is relevant when doing an elective chest drain for a simple pneumothorax or an effusion. But in reality of pre-hospital care, you have to work with patients where they lie. And in this picture, I've already put a chest drain in to relieve the tension, and the IV line is in my mouth because there is nowhere clean to put it down. The knife was pulsating at about 130 a minute, and I didn't want him waking up and starting to struggle. If anyone's talked of purse string sutures and suturing the chest drain in place, forget it. Other people can tape it in place, and your skills are needed in other areas: reassessment, putting an intraosseous access in, anaesthesia, dealing with other patients. Thanks for listening, and I hope that this has been helpful. Comes to you from Patronus Rescue International Limited, and that's not only a training organisation, we also provide remote care paramedics all over the world, and we do various other bits and pieces as well. Have a look at the website www.patronusrescue.com and hope to see you on one of the courses. Thanks for listening.